Hello, my name is Jasmine Valdez, and today I'm going to be presenting for our Occupational Therapy Assistant Program, FieldWork Site 2. My presentation is about motor skills. Motor skills involve complex coordination between the central and the peripheral nervous system, and it's the ability to make movements. Fine motor skills is the ability to make movements using the small muscles in hands and wrists. And motor control is the ability of the central nervous system to direct or regulate the musculoskeletal system in a purposeful activity. Here we have a diagram about how motor control works in our body and through our brain. The only way to move muscles is through motor neurons. They do what they are told and need input from local motor interneurons in order to perform simple movements. More complicated movements are created by central pattern generators. It takes motor control centers to initiate a movement through central pattern generators. There are motor control centers located in the brainstem and motor cortex. Cortical motor control centers are special because the actions occur with meaning. What comes out of the spinal cord is a movement, but what comes out of the motor control center is action. The cerebellum is like a conductor in a band to make sure movements are correct and precise, to make movements spot on, even if never done before. The basal ganglia is involved in the action selection. For example, if you're going to smile or frown or do a turn left or right. There can be a deficit in the pathways that would affect different types of movement. For passive movements, there is a floppy tone, which involves the cerebellum, cogwheel rigidity, which involves the basal ganglia, reflexive, areflexia means that there is no reflex. Hyperreflexia means that there is a deficit in the reflex and interruption to motor neuron, the nerve going out to the muscle or the muscle. Hyperreflexia is a briskness to the reflex, and it means that there has been a damage in the cortical spinal tract. A stereotype would be walking, standing, chewing, and these movements are done through the central pattern generator. Self-generated would be volitional or deliberate. It's more movements like Simon Says movements, like raise your hand, kick your leg out, smile. And here is a sample of a volitional facial paralysis. This lady was told to smile, and as you can see there, she can only smile on her left side. But when she laughs, it's an emotional movement at something funny. The smile response is way different, as you can see in the picture. There are different kinds of assessments. There is a graded Wolf motor function test, different arm and finger movements while being timed. The Fugel-Meyer assessment is a volition movements that involve the wrist. Arm motor ability test is functional tasks like cutting meat, opening jars, donning t-shirt. A motricity index assesses the client's ability to pinch a cube, their pincher grasp, elbow flexion, shoulder abduction, ankle dorsiflexion and knee extension, and hip flexion. Assessment of motor and process skills would be assessing It assesses the quality of performance in ADLs and IADLs. After these assessments, muscle tone is assessed. Muscle tone is a resistance felt by the examiner as they passively move the client's limb. It should be high enough to resist gravity, yet low enough to allow movement. Normal muscle tone relies on normal function of the cerebellum, motor cortex, basal ganglia of the midbrain, vestibular system, spinal cord, and neuromuscular system. Abnormal muscle tone. In order to plan the appropriate intervention, we must recognize the differences among these abnormalities. Flaccidity is the absence of tone. Muscles feel soft and offer no resistance to passive movement. Hypotonus is low tone and is the result of weakness. Hypertonus is increased muscle tone. Upper motor neuron pathways are damaged and is the cause of this. Treatments include sensory motor approaches, casting, physical agent modalities, like diathermy. We can also do ultrasound and TENS unit or ESIM. Distal to proximal approach, which would be a dynamic orthosis, which is the picture that's there on the slide. There are also surgical methods that can be done, and also pharmacological agents, which are medications that can be given to the patient to help with the different kind of muscle tones. What can affect fine motor skills? Being premature at birth, Down syndrome, muscular dystrophy, cerebral palsy, and stroke. Now let's talk about some therapeutic activities. We can incorporate the use of multiple parameters such as balance, strength, and range of motions for a functional activity. The importance of therapeutic activities is used to learn new tasks, can help with de-stress and anxiety, depending on which activity, and help boost confidence, the way that we grade them or the way that we present them to our patients. We, as therapists, should be able to tell like if our patients are able to do something or if they're not, and how we should grade them in order for them to feel like they have accomplished something. So here's some different ones that we can use. I have made a booklet of closures for my site. I felt that this was needed there. They have nothing like this, and they get a lot of hand therapy patients that could use this, and we can see how they can do with the closures. Sometimes when we go to the inpatients, they're already dressed and showered and everything, so we can't really assess how they do with the different kind of closures, so we can bring this in. And also patients that are outpatient. We have inpatients, outpatients, and home health. And this would be useful for them so that they could see how the patients manage to open and close them. Since we have patients that have different kinds of hand diagnosis, like carpal tunnel, trigger fingers, and ligament lacerations and different things like that. There are different kind of closures. There is zippers, there is Velcro, shoelaces, buttons. Who would need this project? Somebody that has Parkinson's, somebody that has gone through a TBI, a stroke, somebody that has MS or is suffering from dystonia, somebody that has neuropathies, men and women of all ages. Here is a page for activity analysis, skills that are needed, the use of at least one hand, since we have learned how to do closures and manage with just one hand in our program. I figured that if the patient just has use of one hand, then they can use this closure booklet. Able to move fingers using the fine motors, at least some movement, and coordination in the hand or hands. Skills that are not needed would be the use of both hands, be able to stand, be in a specific position, and endurance. They can do this booklet sitting down to preserve energy. What can OT practitioners do? We can maximize functional grasp patterns. And here's some grasp patterns that we have, functional and non-functional. Use supportive splints, activity modifications, and assistive equipment. Some other activities that I researched and looked up would be for fine motor skills is a use of a hole punch to make a design on a piece of paper, puzzles, pick up small items with tweezers, mini playing cards like these little Uno cards that I have pictured, or there are also regular playing cards that are that size, and stringing beads. Here is my reference page, and thanks for watching.